dignitaries. It is with great pleasure I welcome Dr. Naveen Malhotra sir, President Rsacp. We are thrilled to have with us a true pioneer in our field, and words are less when it comes to describing the profound impact that sir has had in our field, especially in the groundbreaking work in pain medicine that has inspired and shaped the careers of countless professionals. We are fortunate to have you with us, sir, today. Please welcome. It is an absolute honor for me to welcome Dr. Vishal Singla, sir, Secretary Rsacp. He has not only advanced knowledge in the field but also mentored and inspired countless professionals who follow his footsteps. It is my honor to welcome Dr. Sunil Sethi, sir, Treasurer Rsacp. Your expertise and dedication are invaluable to our organization. It is both an honor and a privilege to welcome our esteemed chairperson, Dr. Anju Griwal, ma'am, President-elect Rsacp. Please welcome, ma'am. Ma'am is known for her exceptional leadership, vision, and commitment to excellence in the field of obstetric anesthesia. It is with my great honor to welcome our next chairperson, Dr. Deepa Ghanshyam Kane, ma'am. Please welcome, ma'am. We are truly fortunate to have an esteemed leader guiding us through this event, her area of interest being cardiac anesthesia. It is an honor for me to welcome Dr. Anil Verma, sir, Professor, National GC member RSACP, who has worked tirelessly to make this webinar possible. He is known for his dedication in fostering a positive learning environment among all students. I welcome you, sir. I welcome our esteemed faculties who have taken out time from their busy schedule for our webinar and joined us today. I welcome Dr. Prem Raj Singh, sir, Professor, Department of Anesthesia and Critical Care, KGMU. Sir will be the leading anesthesiologist in our case. I welcome Dr. Sangeeta Arya, ma'am, Professor and Head, Department of Obs and Gynae, Dr. B.S. Kushwaha, Institute of Medical Science, Kanpur. Ma'am will be the leading obstetrician in our case. Please welcome, ma'am. I welcome Dr. Yashwant Rao, sir, Professor, Department of Pediatrics, GSPM Medical College, Kanpur. Sir will be the leading pediatrician in our case. Please welcome, sir. I welcome Dr. Avdesh Kumar Sharma, sir. He is Professor, Department of Cardiac Medicine, LPS Institute of Cardiology. Sir will be our leading cardiologist today. Please welcome, sir. I also welcome all the senior members of the society, all the GC members of RSACP, all my colleagues, and all my dear juniors. Before proceeding with the session, I request Dr. Naveen Malhotra, sir, to please speak few words and give his blessings.
Thank you, Dr. Neha. Greetings to all the esteemed members of RSACP, the chairpersons, speakers, and distinguished delegates. We recently concluded a very successful RSAP Con 2025 at Saint Lakinda, Punjab. And we are kickstarting our next academic session. And what a theme it is. It is absolutely coinciding with the World Health Day 2025 theme, Healthy Beginnings and Hopeful Futures. The theme of WHO this year focuses on health of mothers and babies. And they say that it is the foundation of healthy families and communities. And we have to ensure hopeful futures for them and for us. And I'm very happy to know that Dr. Anil Kumar Verma, National GC member and President of RSACP UP State Branch, along with his team, has taken a leaf out of this theme and has planned, I'm very sure, an exceptional panel discussion, which is a multidisciplinary involving the cardiologist, anesthesiologist, the obstetrician, and the pediatrician. And they will be ably supervised by Dr. Anju Griwal and Dr. Deepa Kane. And it will be an academic treat for all of us. I'm very sure about it. And Neha Mishra is our RSAP Governing Council member, youth representative. She was with us till late night on the online meeting, and we were planning giving final touches to the RSAP Youth Conclave, which will be announced on this Sunday. So welcome to this particular webinar and to all the forthcoming academic, clinical, and research activities of Research Society of Anesthesiology. It's my privilege to welcome you all as the National President of Research Society of Anesthesiology. Thank you very much.
Thank you, sir.
Uh,
Now I
Neha,
request. Yes, sir.
I'm visible. There is some glitch in my Zoom. I'm visible to you?
Yes, sir.
Okay. Thank you. Thank you. Thank you. There's some glitch was there in on Zoom. Okay, it's fine. It's fine.
Okay. So now I request Dr. Vishal Singla, sir, to please speak few words.
Good evening, everyone. Thank you, Dr. Neha. And
Yes, sir.
I thanks to each and every one of you for being here with us today. Rsacp has always been a pioneer in promoting academics, and we have been holding webinars since long, ever since COVID came in. We are keeping this trend alive and continuing in the same spirit. We would be holding webinars with the more relevant topics. As President Sir told you that our new year begins with after the RCCP conference is done. After the successful completion of RCCPCon 2025 at AIIMS Bhatinda, the new year has begun, and it has begun with the bang, with so many activities lined up. But for today's topics, I would like to congratulate Dr. Anil Verma sir and team Kanpur for bringing up such an innovative new kind of discussion, and that would be a panel discussion involving multidisciplinary approach. I would also like to thank our chairpersons, Dr. Deepa Kane madam and Dr. Anju Gariwal ma'am. And I'm sure that the discussion would be very interesting, lively, and very fruitful for all the audience. Once again, I would like to thank each one of you for being with here us today. Please enjoy the session. Thank you very much, ma'am.
Dr. Neha, here I'd
Thank you,
like
sir.
to add on one more thing,
Yes, sir.
that every fourth webinar of Rsacp will be dedicated to the youth. All the speakers in that particular webinar will be less than 40 years of age, and they will be guided by chairpersons like us, who are young, but numerically more than 40 years of age. I know we all are young. And I'm pleased to share this with you, that this idea was given in yesterday's online meeting by none else than Dr. Neha Mishra from Kanpur. So, and she has given a good suggestion. So every fourth webinar of RSCP, the speakers will be less than 40 years of age, and chairpersons will be more than 40 years of age. Thank you, Dr.
Thank you,
Neha.
sir. But that was led by Dr. Anil, sir, actually.
It's the teamwork.
That's it.
Good.
Okay, sir. Thank you, sir. Okay, sir. With the permission of the chair, can I start the session, sir?
Yes,
Please go ahead. Please go ahead. Over to Dr. Anju Grewal and Dr. Deepa Kane, and I request Dr. Anju Grewal to carry forward. Over to you.
thank you so much. Very good evening. Thank you, Neha, and all of you for curating this wonderful webinar. I think I'll hand over the mic to Dr. Anil Verma to start the proceedings of this excellent webinar topic on multidisciplinary perioperative management of a primary gravida with moderate mitral stenosis and anemia. Over to you, Dr. Anil.
Thank you very much, madam. Good evening, sir. Good evening, Dr. Singla, madam, and Dr. Kane. And welcome to my panelist. And it has been tried to make it more informative and more innovative, so that multidisciplinary approach, as well as there must be a good representation of every specialty, as well as a good tuning between all the specialties. Because in such cases, unless until the multi-speciality involvement is there, it would not be a successful outcome for this. So our moderator is Dr. Neha Mishra, and our four panelists, as everybody is knowing them, Dr. Prem Raj, Dr. Abdesh Sharma, Dr. Yashwant Kaur, and Dr. Sangeeta Arya. So I request Dr. Neha to please start with this panel discussion. Let us hope that it would be a very informative and a joyful panel discussion. So
Thank
please,
you,
Neha.
sir. Yes, sir. To begin with, rheumatic heart disease is still a major concern in India, especially in pregnant women. And as we know, the mitral stenosis is one of the very complex conditions that actually requires a meticulous planning. So today, let us explore the importance of multidisciplinary team approach and also the perioperative management of such patients. So let us assume that we are receiving a patient in emergency department, a 34 weeks primary pregnant female who is 35 years of age and with a history of breathlessness, progressive in nature since the end of second trimester. On examination, she is found to be disoriented with a respiratory rate of 24 per minute, heart rate of 104 per minute, which is irregular, with a blood pressure of 104 by 68 millimeter mercury. On chest auscultation, there are bilateral basal crepes and functional murmur present. The weight of the baby is 2.3 kg as per ultrasound. The investigations are hemoglobin 7 gram percent. So as we can see that it is less, with the ECG findings of left atrial enlargement and right ventricular hypertrophy, and the echo findings of mitral valve area 1.2 centimeter square with the ejection fraction of 55%. I would like to open the discussion with our obstetrician, Dr. Sangeeta Arya ma'am. Ma'am, can you please tell what are the key concerns and considerations that comes in your mind as an obstetrician when managing such a case, and how will you approach such a patient?
Very good evening to everybody. My namaskar to Naveen sir, Sigla sir, and all the respected faculty members here and listening delegate members. Being Dr. Neha, as the
Yes,
patient has come here as a first in emergency to an obstetrician, the whole of the responsibility comes on our shoulders to associate with other team members also. As she has come with a breathlessness and she's in an acute condition, first of all, we will give her the first aid treatment. We will obviously admit her. We will keep her in the proper position, give her oxygen so that she gets comfortable, and later on we have to send the investigations. My concern would be here, she's the elderly primary gravida, aging 35 years, and in the late second trimester, she started having breathlessness as well as, and as you have told us that she was already a known case of mitral stenosis. No patient can get severely, or like within few days, she will get into the category of severe anemia. If she is anemic, either she is not compliant to the treatment previously, whatever been given to the this patient, or she is having some kind of hemoglobin. So this is our concern, and as with every patient, we have to take once she is stabilized further, we have to take detailed history. Detailed history I take in terms of the obstetrics, what was her LMP, what will be the EDD, how she is progressing now, and what were her previous records. We have to see for that. As well as we have to see in terms of cardiology also, what is she is a known case of mitral stenosis, what previously treatment has been given, she has followed it or not, what other medications were being given. The second point which is shown here is that she has got 34 weeks pregnancy with birth weight of 2.3, which is estimated by ultrasound. So we are not much concerned that she is having a IUGR baby, which is usually common in such cardiac cases. I think she is not in labor. Although we have to assess that she is in labor or not. According to your slide, she is not in labor, but still we can consider her for the steroid coverage in these patients if she further lands up in labor. And the other thing is that if she is having any kind of infection, if we don't see any kind of infection, she has been previously given benzathine penicillin for this rheumatic heart disease, she is taking regularly, then there is no need. And the investigations, along with she is having acute distress, for this we have to send the ABG. If previously no investigations has been done, we have to do the routine which we do in a normal obs patient. Along with that, we have got a concern that she is severely anemic. For that I would like to do the serum ferritin levels to rule out the cause of anemia, do a PBS, peripheral blood smear, to rule out any kind of helminthic infestation is there, or stools also. Sometimes very intelligent persons are losing blood through stools. They become anemic in these part of second trimester or early third trimester. We have to rule out that also. And if there is some kind of hemoglobinopathy, then we have to see for that. Agar wo anemic hai, so then I would prefer giving her FCM. So, and on this time only, we have taken the history, we have done the examination, ruled out she is not in preterm labor, but still we have to counsel all the family members, her husband, and other family members. We have to sit together, they will be counseled that this is not the situation. We should ideally be in the early third trimester, that she has become anemic. This is a grave situation. And we are sending this reference to the cardiologist who will be seeing the cardiac part. If in labor, the pediatrician will be looking after our baby. and for how many days you will be admitted with us, what we will be doing, what will be the scope of our treatment, and if you get discharged from here, then what will be your further clinical follow-up, after how many days you have to come for follow-up to us, as well as counseling when you land up in labor, what will happen, which I think we will be dealing with further slides. So
Right,
at
ma'am.
the first, yes, we will be dealing further. At the first, हमें कुछ भी मौका नहीं छोड़ना है. We have to deal with everything. And yes, please, as a obstetrician, as with other faculty members also, other fraternity members also, we have to document each and everything. Whatever we are telling, एक बंदा है जो write down कर रहा है कि we have told this is there, and this is the history, this is the examination, this will be the everything is documented. Thank you.
Right, ma'am. Okay. Ma'am, before proceeding with the case, can you please tell us what are the normal cardiovascular changes that occur during pregnancy to accommodate the growing fetus?
Yeah, to accommodate the growing fetus, the nature has given such a beautiful, predictable, and expected hemodynamic changes usually occur in a female. Twins and multifetal pregnancy, we have got other changes, and these changes get exaggerated when our patient has come. If she is anemic, then these changes will be exaggerated. There are structural changes occurring in the left ventricular, slight changes. These occur in a normal pregnant female when she is having hemodynamic changes. There is activation of renin-angiotensin aldosterone system, which causes the sodium and water retention. Sometimes females get swollen up and they get to increase the plasma volume basically. And along with this, these have got the hormonal fluctuations. These hormonal fluctuations lead to the decreased SVR. So the term is that the baby should placental vascularity should be maintained. Here the preload is increased, afterload is decreased, SVR is decreased, just as to maintain the placental perfusion better.
Okay. So as we can see, the cardiac output increases. So with these normal adaptations, Dr. Yashwant sir, is there any benefit to the fetus?
Yeah. So Dr. Sangeeta already told कि मतलब 34-week pregnancy and mother is anemic hemoglobin is 7. So due to anemia, to increase the oxygen content of the blood plasma volume will be increased by 50%. And very important is to maintain the uteroplacental circulation, because ultimate outcome of pregnancy is the baby. Baby should be okay. There should be no hypoxia. And already Dr. Sangeeta told that there is the adaptive changes that decrease in systemic venous resistance to increase the uteroplacental circulation. Because baby's weight, it depends on almost universally directly proportional to the uteroplacental circulation. So two things are there. One is increase in blood volume, and second is decreasing systemic venous resistance. So I would like to say to maintain the hemoglobin, ideally should be at least more than 10 gram %, so that the adequate oxygenation will be there.
Okay, sir. So I think along with the adequate perfusion, the baby will also receive adequate nutrition.
Yeah.
Okay, sir. Dr. Avdesh sir, can you please give your insights on the typical findings of the mitral stenosis?
Yeah, Dr. Nia, thank you. First of all,
Yes.
thank you to all for inviting me in this
Thank you, sir.
prestigious webinar. As you had already stated, that patient is known case of severe mitral stenosis, and patient currently is in a state of heart failure because there is bilateral clefts in the chest that is suggestive of patient is in CHF. That is a complication of mitral stenosis. And also patient is in atrial fibrillation. There is arrhythmia also. And but because pulse is irregular in your case. So because of atrial fibrillation, patient is more prone for different thromboembolic episodes, and patient is already anemic, and we are also giving anticoagulant to the patient. So that's another concern. So in this patient, my main concern is that is anemia, because anemia is a worst prognostic factor in this patient, because it further increases the transmitral gradient and further worsen the condition of the patient in majority of these cases. And if I talk about the findings in mitral stenosis, then basically, if I talk about on clinical point of view, then basically these patients present with long-standing dyspnea of 4 or 5 years duration, and it gradually worsens from NYHA class 2, then NYHA class 3, and ultimately in class 4 when patient is in heart failure. and different conditions worsens the situation. Like anemia is a bad or stressful environment, and different, and also pregnancy itself is a stressful condition because it increases the transvalvular transmitral gradient and further increases the pulmonary venous pressure and pulmonary capillary base pressure and pulmonary venous hypertension. And infective endocarditis is another concern, and recurrent episodes of carditis is also a concern in this patient because it's a young patient. So whether she is taking benzathine prophylaxis or not, it is not clear as per our history. And so dyspnea, breathlessness of long duration is an important finding. And if I talk about on clinical examination, then definitely presence of atrial fibrillation in the form of irregular pulse is suggestive of mitral stenosis. And if I auscultate the case, then there will be loud first heard sound with opening snap and with mid diastolic rumbling murmur that must be present in this case. And there must be signs of pulmonary artery hypertension in the form of loud P2 or tricuspid regurgitation. And if on the investigation part, if I talk, then on ECG, there might be left or right atrial abnormality. As we can see in this case, that ECG of the patient, there is P mitral, that is left atrial involvement, which we see in lead 2. The duration of the P wave is more than 120 milliseconds, and there is bifid P wave. And the duration or time duration between the two peaks of the P wave is almost more than 40 milliseconds. And there will also be right axis deviation. Right axis deviation is basically denoted by negative RS complex in lead 1. In majority of the cases in lead 1, there is always positive QRS complex. But if there is negative QRS complex in lead 1, then it is only seen in right axis deviation. So right axis deviation, right ventricular hypertrophy, left atrial abnormality in the form of bifid P wave, that is P mitral, is suggestive of severe mitral stenosis. And then I will like to do 2D echocardiography to assess the severity of the mitral lesion and also to assess the pulmonary artery pressure. Because if it is the mitral valve area, normal is 4 to 6 square centimeter. If it is less than 1, then it is severe. If it is 1.1 to 1.5 square centimeter, then it is moderate. If 1.5 to 2.5, then it is mild. Similarly, the mean gradient across the mitral valve, I would like to assess higher, the more the severity. If it is more than 12, then it is severe. 6 to 12 moderate, 2 to 6 mild. And similarly, pulmonary artery mean pressure, if it is more than 50, then it is severe. If it is 30 to 50, moderate, or if it is less than 30, then it is mild. And I will also like to assess the compliance or pliability of the mitral valve, whether it is calcified or non-calcified. Based on those findings, I can further plan whether I can do mitral balloon valvotomy in this case or not. Because if valve is heavily calcified, or if there is clot in the left atrial appendage or left atria, then I will like to prefer to send it to surgeon, cardiac surgeon for either commissurotomy. And if the valve is pliable, no calcification, no LA appendage clot, then I will like to prefer balloon mitral valvotomy in this case. So these are my concern specifically in this case. And before that, I will like first to manage medically the patient by IV diuretics to relieve his symptoms of heart failure, and manage or control the heart rate because of atrial fibrillation, because it is in fast ventricular rate and the rates are irregular.
Right, sir. Now, with the above findings of mitral stenosis, how will you stratify the risk of the above patient as an obstetrician? Dr. Sangeeta ma'am?
Basically, this risk stratification is to guide the clinical decision making and in management strategies, like how much close monitoring and specialized monitoring will be required in these patients. As sir has done, he has done the echo of the patient, all the ECG findings are with us, and along with the history of the patient's previous history, either she is having prosthetic wall, whatever her medicine status, she is having severe MS or having AI also, hypertension also. So we have to take these all factors. We just stratify according to, we have 2-3 classifications. One is the modified WHO classification, in which we take 7 points, and it's 7 point. these points are given numerical values to every point. According to that, we find out the score of the patient in this key, what is the score, and how much will be the risk or the adverse effects or the complications can occur in the future period. So this is the risk stratification. The other method by which we can do the risk stratification is the Zahra method. Zahra method scoring system is basically for the congenital heart disease, but it's applicable in these patients also by in the mitral stenosis. These have got, I think, 8 points. We have to we can't remember everything, but we have to take the history according to them. We have to rule out those points so that we can stratify these patients, how much she is carrying the risk, and for the future cardiovascular events, and even she can die also. She can have a great morbidity as well as mortality. So it will be easy to explain to the attendants as well as to document. This risk stratification becomes very important in these cases, so that we document also to save our necks further, and we can, yes, we can give the good treatment to the patient so that our outcome is good. The other is the CARPREX 2 score as seen on the screens. We have to see for the prior cardiac event. This is a very good method. And if the score increases, the risk of the cardiovascular events during our treatment increases. So we have to deal according to that, and we have to counsel the patient as well as attendant according to that.
Right, ma'am. Now, considering the patient's diagnosis of mitral stenosis, as we have seen, and her pregnancy status, Dr. Avdesh, what would be your recommended course of treatment in this patient to ensure that the both baby and mother are fine?
Dr. Neha, as I had already calculated the risk score which we are talking, then as per CARPREX risk score, it is more than 1. So almost there are 75% chances of maternal-fetal complication during the whole period, peripartum, prepartum, or postpartum period. So definitely it is a very high risk pregnancy. And I can say that any pregnancy involving left-sided valvular involvement, either mitral valve or aortic valve, especially stenotic lesions, then definitely it comes under the high-risk pregnancy. So definitely patient is under high risk category, and we must sincerely act as a team effort to reduce the maternal-fetal complication. And if I talk about the management in this case, then if I talk during pregnancy, then if there is severe MS, as it is already in these patients, then if patient is symptomatic, then and valve is pliable as per on 2D echocardiography report, then definitely balloon mitral valvotomy is a suitable option to relieve the symptoms and to improve the clinical condition of the patient and to reduce the maternal-fetal complication in this case. And the patient is also in 34th week of gestation. That's a suitable period for any cardiac intervention in these cases, because second trimester after the 12 week is the most suitable period for any cardiac intervention, because uterus is not so large, and the fetal thyroid is not so active, and the distance between the chest and the fetus is widely separated, so there is less radiation hazard to the patient, and we can safely do balloon mitral valvotomy in these cases by protecting the gravid uterus with the radiation protection shield in this case. And if I talk about pre-pregnancy period, then if it is severe MS or moderate MS with symptoms, then definitely some intervention is needed in the form of balloon mitral valvotomy. And if it is mild MS, then we can continue with medical therapy in such cases. And the other thing is presence of atrial fibrillation. That is itself is a birth prognostic factor in such cases, because atrial fibrillation can increases the risk of thromboembolic episodes, and in severe mitral stenosis, 40% mortality causes are because of stroke or thromboembolic episodes. So we must act on this part also. So if there is presence of hemodynamic instability, patient is in state of shock, then we must direct cardio, but the patient irrespective of the pregnancy status of the patient, and initiate the anticoagulation therapy. And in anticoagulation, we must prefer vitamin K and vitamin K antagonist in such cases. And if there is absence of hemodynamic instability, patient is not hemodynamic stable, and the atrial fibrillation duration is less than 48 hours, then we can directly DC cardiobert and start anticoagulation therapy. And if it is chronic or persistent atrial fibrillation, which is the case in majority of the mitral stenosis cases because of left atrial dilatation, these patients are usually present with chronic persistent atrial fibrillation. So in these cases, we fully anticoagulate the patient for 4 weeks, and we also do the transesophageal echocardiography to rule out any left atrial appendage. And if there is no left atrial appendage and atrial fibrillation is of recent onset, then we can DC cardiobert the patient. But if it is of long duration, then our main motto is to control the rate in these patients, and our main strategy is rate controlling strategy with the help of either beta blockers or calcium channel blockers, and we will definitely use only those drugs which are pregnancy safe, especially beta blockers or calcium channel blockers and digoxin, because cardarone is not safe in pregnant females. And we also start oxygenation, proper bed rest should be given to the patient so that maximum stress can be avoided, which can avoid tachycardia in this patient, which can further worsen the clinical condition of the patient. And we must also start rheumatic prophylaxis in the form of benzathine prophylaxis injection of 1.2 million unit deep intramuscular injection after doing sensitivity testing in such patients. And for heart failure, for decongestive purposes, we can start IV loop diuretics, keeping in point the risk of oligohydramnias in these patients, definitely.
Right, sir. That was the outline of the recommended treatment. Now, can you just walk us through the pharmacological agents specifically used for this patient, and also what about their safety profile in pregnancy?
Yeah, definitely, Neha. Our main, the first drugs which we are using in these cases for relieving the symptoms of heart failure are diuretics. So in diuretics, the safe diuretics are furosemide, are the safe diuretics. And then the second line of choice is rate controlling agents. In rate controlling agents, beta blocker, that is metoprolol, propranolol, or digoxin are safe in this group, pregnancy patient group, but amiodarone is not safe in pregnant patients. And if I talk about use of anticoagulant because of presence of atrial fibrillation, then definitely vitamin K antagonist in the form of warfarin or unfractionated other anticoagulant like unfractionated heparin or low molecular weight heparin, enoxaparin are safe in this case. But atenolol and ACE inhibitors should not be used in such cases because of risk of teratogenesis or organogenesis. And if I talk about oral vitamin K antagonist, then definitely in first trimester these should be avoided up to 4 to 6 weeks because of risk of effect on the organogenesis. And if we are planning to use them, then they must be used in lower doses, like warfarin must be less than 5 milligram, or if we are using esnokumodal, then the dose must be less than 2 milligram in this in such scenario.
Okay, sir. So now coming to the anticoagulation part, anticoagulation in pregnancy is another complex issue. So can you walk us through the anticoagulants which are commonly used in pregnant females, sir?
Yeah, if I talk about safe anticoagulant during the pregnancy period, then definitely they are low molecular weight heparin or unfractionated heparin. So on that, if we start from day 1, then we can start with low molecular weight heparin, or after the first trimester, we can start also low dose vitamin K antagonist in the doses of, if warfarin, then less than 5 milligram, or esnokumodal acetron, that is less than 2 milligram. And then we can continue with either low dose vitamin K antagonist or either with low molecular weight heparin. And at the time of 36 week of gestation, we must replace it with unfractionated heparin based upon the high risk category of the patient. If 36 hours before delivery, if the risk is high, then we must switch over to unfractionated heparin. And we stop unfractionated heparin 4 to 6 hours before delivery, and we can start 4 to 6 hours later on after delivery. If the patient is of low risk or low risk of bleeding, then we can stop low molecular weight heparin 24 hours before delivery, because to avoid the risk of bleeding. And if after 4 to 6 hours post delivery, if the patient is high risk, then we can restart unfractionated heparin, or if the patient is low risk, then low molecular weight heparin prophylactic doses can be used, and which can be 12 hours later start with last therapeutic doses. So basically, up to 36 week of gestation, we can continue with vitamin K antagonist in lower doses. And after 36 week of gestation, we must start either low molecular weight heparin or unfractionated heparin. And these must be stopped 4 to 6 hours prior to delivery, and then can be start 4 to 6 hours after the delivery, because low molecular weight heparin and unfractionated heparin causes less bleeding, and we have control over them if there is some bleeding in the form of antidote like fresh frozen plasma or vitamin K injections. So we can prevent that bleeding up to some extent in such cases.
Right, sir. So it is clear that anticoagulation in pregnancy requires very careful balancing between the benefits and the risks,
Yeah,
and with monitoring, of course.
especially during the first trimester, up to 12
Right.
weeks, we avoid higher doses of vitamin K antagonist. Like if we are using warfarin, then it must not be more than 5 milligram. And if we are using acinocumaril, then it must not be more than 2 milligram. And during the initial days of pregnancy, it is always better to use either unfractionated heparin or low molecular weight heparin to prevent its effect on organogenesis.
Okay,
And
sir.
after completion of the organogenesis, or that is after 12 weeks, we can continue with the vitamin K antagonist, and then they have to stop just at the period of 36 weeks of gestation. And then we can decide either we will use unfractionated or low molecular weight.
Okay, sir. Now proceeding further. Now, one of the matter of classic debate between anesthetists and the surgeon is the ideal coagulation profile and the platelet threshold for pregnant patient in elective and emergency surgery. So can I get the opinion of Dr. Sangeeta Arya ma'am for this?
Yes, basically now we don't have tussle with our anesthesia persons. We usually trust them. We can save the patient. But yes, if the already we have got now as an obstetrician, we are seeing that many of the prescriptions are loaded with the ecosprin. Aspirin is being given very frequently to the patients. Sometimes patient land up with that. If we are seeing those kind of patients, we have to obviously start with 7 to 10 days. Like sir has said that we have to stop this by 36 weeks warfarin as well as the ecosprin. If patient lands up early in this labor, then we have to very cautious about that. So 7 to 10 days before delivery, planning the delivery of the patient, we have to stop the ecosprin as well as the warfarin. We have to switch over. Already Avdesh sir has told us in detail. The ideal, as we can see, the INR is to be kept less than 1.5. If the patient is having the prosthetic wall, then we have to keep this INR between 2.5 to 3.5. This can be labile, but yes, ideally in all the patients, we have to keep this INR, and platelets below, like above 75,000 do well with us. We are not worried to put our put the incision when the patient is having above 75,000. And luckily, if we get 1 lakh platelet count in these patients, and PT, APTT, if not in the normal ranges, we are ready with our FFP, as well as if the platelet count is not good, we are ready with our platelet infusion packs.
Right, ma'am. So I hope it is clear and the tug of war between the anesthetist and surgeon would not occur. The slide is not going forward.
मैडम लड़ाई हो रही है.
नेहा थोड़ा सा
Yes, right.
Okay.
So now when it comes to safe anesthesia, what do you think should be the ideal coagulation profile and platelet threshold and for optimal patient care? Dr. Premraj, sir?
Yeah, first of all, good evening, everyone. I want to thank Rsacp Society, Naveen sir, Anju Grewal ma'am, Anil sir, and Neha for this wonderful opportunity.
Thank you,
Now,
sir.
coming to the questions. So, why coagulation profile and platelet threshold matter to us? So, why it is important? Because our epidural or spinal anesthesia require puncturing vascular-rich spaces, basically the epidural venous plexuses. So, अगर वहाँ पे coagulopathy होती है, then there is a chance of increased risk of spinal and epidural hematoma. so which may lead to a permanent neurological injury or paralysis. So what ASA and SOAP Society recommend a platelet count of more than 70,000 for spinal anesthesia. But if there is emergency, you can proceed with the 50,000 also. But for epidural placement, it should be more than 70,000. And INR value should be less than 1.5, and APTT should be less than 40 seconds. Yeah.
Right, sir. Okay, to proceed further, since the mother is on anticoagulants, Dr. Yashwant sir, is there any possibility that there will be bleeding the newborn as well? And if it is so, how can we manage it?
Yeah, actually, my job already done by Dr. Avdhesh. So basically, during first trimester, we should avoid warfarin because this is the time of organogenesis. And warfarin, when crosses the placenta, they are teratogenic, like they can cause skeletal abnormality, major hypoplasia, craniofacial malformation. In CNS, they can cause microcephaly and as well as developmental delay. And during third trimester, in the late period after 36 weeks, you have to stop. But if you are giving, so that can cause bleed in the mother, and it can cause spontaneous abortion, abruptio placenta, and even in neonate, it can cause fetal bleed like intracranial bleed. So safely we can give warfarin in second and third trimester, but it should not be given in first trimester and after 36 weeks of the pregnancy. And choice is already told by Dr. Avdhesh ki low molecular weight heparin or heparin. So heparin are safe both during pregnancy and as well as lactation.
Right,
Now
sir.
coming to the management part, because transition to the safer anticoagulants already done, already supposed. But if there is chances of bleeding, so we should immediately give vitamin K to the newborn at birth if child is bleeding, and immediately transfuse FFP, fresh frozen plasma, to stop the bleeding, and keep the baby in NICU to further management if any.
Right, sir. Now, when it comes to treatment of mitral stenosis, we hear often about percutaneous valvuloplasty. Dr. Avdesh, what is the role of this in our treatment and how to proceed in our case?
And definitely, Neha, nowadays we are treating a lot of pregnant patients, and in my cardiology career, I had treated almost 20 to 25 pregnant mitral stenosis patient with percutaneous balloon mitral valvotomy. So definitely, it's a good option, especially in those patients in which valve is not so much calcified, valve is pliable. That be calculated on the basis of 2D echocardiography. There are different scoring systems. One of them is Wilkins scoring system. If it is less than 8 and there is no commissural calcification, then definitely these cases are suitable for balloon mitral valvotomy. So those patients who are having severe mitral stenosis, that is mitral valve area less than 1.5 square centimeter with presence of symptoms, then definitely these patients must undergo balloon mitral valvotomy, and especially during second trimester, because as I had already stated, this is the safest period to do any cardiac intervention, and really the results are very good, and majority of the patients get drastic symptomatic relief by percutaneous balloon mitral valvotomy. Only in fewer percentage of cases where the valve is heavily calcified or patient is in severe state of heart failure like NYHA class 3 to 4, then these cases are to be referred to cardiac surgeons for open commissurotomy or closed commissurotomy, and except in majority, I can say almost, because majority of these patients are young and their valve is almost not so much calcified. So more than 90% of the patient can be easily tackled with balloon mitral valvotomy in such cases, and it almost had 100% success rate, and it reduces the maternal-fetal complication in such cases.
Right, sir. So I think it is clear that PCV can be a game changer for most of the patients.
Yeah.
So now when managing a patient with the above conditions we have discussed, how do you prioritize obstetric care in these patients for a better maternal and fetal well-being? Dr. Sangeeta ma'am?
Madam, it is the individualized case assessment. We have to see how much emergency is we have to take out the baby. Like babies having fetal, we are having fetal distress, the patient is in labor, she can't tolerate the tachycardia. We have For the survival of the mother as well as the baby, we have to do the urgent any delivery or cesarean section. Obviously, we can go for the cesarean section. We can't expect urgent delivery within 30 minutes or so in 1 hour. If we have got time to salvage the mother and the conditions can be restored, like her anemia levels can be restored, the baby can be salvaged, like if the baby is having IUGR or further this kind of we get the changes in NST, we have to take out the baby in 2 to 3 days. Still we get the time of 2 to 3 days, then we can salvage further, stabilize the mother as well as the baby, and then we can go for the delivery decisions. So these are all the cases of individualized assessment according to our OBS condition, the baby condition of the baby, as well as what the cardiologist is saying when the baby is to be taken. If she is stable, we can give her time. We should take the time till her 37 or 38 weeks are completed in these cases.
Right, ma'am. Okay, ma'am. So what do you think should be the key components of pregnancy-focused workup, especially in this high-risk patients? Do you have any additional steps or specific steps to ensure better outcome?
Yes, first we have to gather our team. There should be a team workup. We should specifically, precisely explain to the patient that this is going to happen, and along with their family members who come into this category. This is our risk stratification. This is our team. Our team will be seeing you regularly like this. You will be investigated further. Our pediatrician is so and so. And these all the team members, this will be our nursing staff. In this room, you will be admitted. These are the things in the labor. We will be giving you the epidural analgesia if possible whenever you have to come. We have to, like, patient in the written or in patient should be well explained what is to be done to her, and what will be the later consequences, what could be the complications to her, and what she has to face. And in the case the patient has come, she has been stabilized, she is going home, and when she's in emergency, she should be given all the emergency numbers. She has to come in that situation, and the team should be alerted at that time that this kind of patient is coming. So if we give her a proper explanation to her, what will be our plan of care to her, and what could be the complication when you have to come, how you have to come, what will be done to you, she will be having everything in mind. So this comprehensive care, if we giving this to our these females, we can improve our maternal outcome as well as the fetal outcome.
Right, ma'am. So definitely it requires a very vigilant approach and a tailored approach for these high-risk patients. So now coming to another matter of debate, blood transfusion between a surgeon and of course anesthetist. So what do you think should be the factors which decide when to start blood transfusion in such patients? Ma'am, can you please give your opinion first?
Yes. Actually, we are shifting from earlier. We used to, whenever the patient is having 7 or 6 gram hemoglobin, even if she was stable, we used to give her blood transfusion. Oh, she is having severe. Now we are switching our view to the other side. If the patient is hemodynamically stable, she has ample full time for her delivery, like 3 or 4 weeks we have got time, then we usually don't switch over to the blood transfusion. We can usually prefer giving her FCM and all those, because we are getting good responses within 1 or 2 weeks. The patient's well-being, we are able to see that. But yes, if the patient is, whenever she is having hemodynamic instability, she is having less than 7 gram percent, but still she is having hemodynamic instability, and for the improvement of her hemoglobin levels, then we do transfuse blood. But yes, we take the opinion of the cardiologist as well as anesthetist, and if it is required, we take the opinion of the hematologist also. What is the reason? And obviously, according to the investigations, we usually go for blood transfusion. But if we do have time, we prefer not giving blood transfusion. We give her iron in the form of intravenous FCM injections.
So I think if the patient is symptomatic, the hemoglobin threshold for transfusion can be 10 gram per deciliter.
Yeah.
And for elective surgery, definitely it should not be less than 8 gram percent.
Definitely.
Yes, sir.
As per se anesthetic point of view, if I say, first we have to see whether we are taking this case as an emergency or elective. If it is elective, then definitely we want to be hemoglobin around 10 grams. Another key consideration, what we have to look for, we should avoid volume overload, because in mitral stenosis, what happens, there is LV inflow obstruction, so it may cause pulmonary edema in intraoperative perioperative period. And when we are giving transfusion, it should be slow transfusion in the cover of diuretics, example furosemide. So we have to take care of this also.
Yes, sir. Okay, sir. Right. Now, and we can see that most of the high-risk patients have got anemia, like in our case. So,
Yeah.
Dr. Premraj, sir, can you please elaborate on how anemia affects our patient's outcome undergoing regional or general anesthesia?
Yeah, the thing is that, as we all know, anemia, what happens, there is a decreased oxygen capacity. So it may cause tissue hypoxia, which may lead to lactic acidosis, which is not good for a patient. So under general anesthesia, there is chances of intraoperative hypoxia, delayed awakening, or poor fetal oxygenation. And under regional anesthesia, it is safer compared to general anesthesia. But in severe anemia less than 8, there may reduce tolerance to hypotension and decrease uteroplacental circulation, though there is chances of profound hypotension. So that we have to look for.
Okay, sir. So whether it is regional or general, both
Yeah.
we have to take care with a proper approach.
Definitely.
Okay. So, Dr. Yashwant, sir, does maternal anemia affect the fetal outcome as well?
Yeah. If there is a maternal mother is anemic, so in the last trimester, iron will be not be transferred to the baby. Baby will be iron deficient. And not only this, mother is anemic, so mother can deliver preterm birth. Low birth weight will be weight will not be gained because of hypoxia and other thing. And not only this, in the later when we follow up the baby after birth, there could be neurocognitive disturbance in the baby. Some autistic disorder can be there, and hemorrhagic complication to the mother could be there because of hypoxia. Uterine contraction will be delayed, so it can cause PPH, postpartum hemorrhage. Due to anemia, the baby will be prone for infection also because for development of lymphocyte and other system, iron should be there, and perinatal mortality could be the problem if mother is anemic.
Okay, sir. So as we can see that anemia does affect the baby immediately after birth, and also it has got long-term complications. So while dealing with such patients of mitral stenosis, do we require higher hemoglobin threshold for a better perinatal outcome? Dr. Avdesh, sir, can you please throw light on this?
Definitely, Dr. Nya. Higher hemoglobin must be there at least up to 10 gram of hemoglobin must be there to avoid the burden on cardiovascular physiology. Because
Right, sir.
presence of anemia, it creates a hyperdynamic situation, and it increase the flow across the mitral valve and increases the transmitral valvular gradient that further increases the pulmonary capillary blood pressure, pulmonary venous hypertension, and patient can land into a state of acute pulmonary edema that carries a worst prognosis in such cases. So at least 10 or more than 10 gram of hemoglobin must be there in such cases to avoid maternal-fetal complication, to avoid different risk associated related to anticoagulation in such patient in this scenario.
Okay, sir. Right, sir. I hope Dr. Sangeeta Arya ma'am agrees with this.
Yes, obviously, in every case.
Right, ma'am. While dealing with such high-risk cases, what would be your choice of mode of delivery, ma'am?
From our forum, we always say the vaginal delivery should be first give first option for every patient. But in this case, when we are expecting the normal labor in these patients, the time duration is not fixed in these patients. The second stage of the labor may be prolonged if the head is not getting rotated, the patient is having pain, anxiety, her heart rate is increasing, cardiac, in this stenotic lesion, her cardiac output is increasing, which is going to worsen her condition more. But if it is an easy delivery, there is no, we should ideally go for the vaginal delivery. But if we see that the labor can be prolonged, the baby's head is not rotating. That means it's an individual decision of the obstetrician. We can go for the straight away. We can, if there is an obstetric indication before going into labor, like there is fetal distress, the cervix is not dilating properly, the pelvis is not adequate. If the labor is going very nicely, with the help of the labor analgesia, we can go for the vaginal delivery. If anyhow we get some kind of indication that she should be taken for cesarean section in the initial phase or in the later phase, better to go for the cesarean section in a controlled way with the whole of the team present in the OT, so that the every situation, because a cesarean section will take around maximum 40-45 minutes, and to the anesthetist from initiation of the your anesthesia till the patient comes out, usually it will be 1 hour. So it will be basically easy if we have got a specialized team, and we have seen the good outcomes of these patients previously also. When they have gone under cesarean section, we could salvage the mother and baby in a very good condition. If it is a control, the team is right, we go for the cesarean section. But yes, from this forum, I can't say, especially if the patient is going through vaginal delivery properly, there is no indication of the second stage, so, and better give her good analgesia so that her vital parameters are controlled.
Right, ma'am. Many obstetricians, ma'am, still prefer cesarean section for, especially with the patients with cardiovascular diseases, as in our case. But in most of the texts, recent texts, it is written that the natural vaginal delivery must be safe for both mother and the baby. Now, why is this discrepancy, and how would you explain it, ma'am?
People are going for cesarean section.
Yes,
that is the main trust on you, anesthesia people, because we are like labor will be for 18 to 20 hours, 24 hours, because the first stage of labor is very extended. We can expect this time the second stage of labor should end. But what is the today's scenario? People don't want to have pain. Haven't got the husband or the family members are having more anxiety than the laboring patient. Nobody has got a time to wait for these things.
Right.
So this may be the reason why people choose the cesarean section. As I have already told, if the patient is going according to our protocol, the patient is normally progressing for the labor, it is a good thing we go for the vaginal delivery if the pediatrician, cardiologist, anesthetist are all there to give us backup. But yes, as it is done, previously been told, it can be we can give the baby to this distressed mother within half an hour to 1 hour, and the whole of the family is also happy. The main stress was on anesthetist as well as the cardiologist to give the good outcome. But yes, the family members and the patient is happy. Yes, 1 ghante ke stress mein we got the results and the patient is stabilized. We have got the ICU backup. This can be the reason, but yes, seriously speaking, we are getting the control. You people are getting the controlled parameters of those patients. You are giving good outcome. I know your pulse rate, the patient's pulse rate, as well as your आपका भी उतना ही cardiac output और वो सब distress and सारा stress वाली finding होगी. अगर आपके levels, hormonal levels check करें तो patient से हो सकता है tally कर जाए. So this is the reason the people, we have got a trust. Although this hasn't come in the guidelines, we should straight away go for the cesarean section. Although some guidelines are mentioning us, but in the ops cases, first, from this forum, I would again say that we prefer vaginal delivery, but yes, in the control team, we have got the option, then yes, we can go for the cesarean section.
Okay, ma'am. So it is a four-cornered obstetricial stress, we could say. Okay, ma'am. That was a wonderful explanation. Now to proceed further, Dr. Premraj sir, while managing this patient, what are the key physiological concerns as an anesthesiologist?
Okay, the thing is that we start with we look as a pregnant patient entails around 50% increase in intravascular volume, which result in a dilutional anemia. There decrease in platelet count. So this patient lead to hypercoagulable state, which may lead to this patient are more prone to deep vein thrombosis. Another important thing in this patient is about the mitral stenosis. This is a state where there is a fixed cardiac output. This patient cannot tolerate tachycardia or fluid overload. Best tachycardia causes decrease in left ventricle filling. Then it should be avoided. then chances of risk of pulmonary edema, especially in third trimester, is very high. Another thing is anemia. Anemia, it causes a decrease in oxygen reserve. So there is a very narrow margin for patient under anesthesia. So we have to look for this in this patient about the anemia also. And according to pregnancy-related changes, there is a reduced functional residual capacity, increased minute ventilation, and oxygen demand. And also, this patient have a difficult airway due to edema and engorgement, and chances of increased aspiration risk also.
Right, sir.
Yeah.
So with the above considerations, what do you think should be the goals of anesthetic management?
So again, our first goal is to avoid the tachycardia in this patient, avoid fluid overload, sudden hypotension, hypoxia, hypercarbia, and acidosis. So our goal should be, our heart rate should be under 60 to 80 per minute. And we should proceed with epidural anesthesia because it is a graded epidural. So it will be a good for patient. Because with spinal anesthesia, there is sudden hypotension. So we have to avoid that. And we have to maintain the oxygenation and normocapnia. And if possible, invasive monitoring like arterial line and CUP is also needed in this patient. Yeah.
So with the above goals, how would you plan your anesthesia?
So as I have told you, we have to plan it stepwise. So first is preoperative evolution, anesthetic type selection, pre-medication, monitoring, and team preparedness. So preoperative evolution, what I have to look for? I have to look for whether patient has a mild, moderate, or severe mitral stenosis. So this patient had around 1.2 centimeters square of area. So a cardiologist consultation, our recent echo, look for the mitral valve area, our coagulation profile, whether patient is on the anticoagulant or not, we have to look for that. Now coming to the anesthesia type of selection, regional or general. As if patient has a mitral valve of area of more than 1.2, then we proceed with the epidural. If no contraindication is there, then with this we also give pre-medication, antacid, H2 blockers, and monitoring. If patient is a high risk, then we go for the invasive monitoring, pulse oximetry, ECG, ETU-CO2. And we have, if patient is anemic, we have to prepare blood also in this patient. Yeah.
So as you told that regional anesthesia is actually chosen for most of the pregnant patients, but regional anesthesia does have its own advantages and disadvantages. So can you please summarize the benefits and drawbacks of regional anesthesia?
So first of all, what it avoids airway manipulations. Then there is stable hemodynamic with epidural because it gives incremental dosing. Excellent post-op analgesia, reduced risk of pulmonary edema if carefully managed and fluid properly managed intraoperatively. And looking to the drawbacks, chances of hypotension is there, and contraindication if coagulopathy or anticoagulants, or patient is on anticoagulants. So we have to look for that also.
Right, sir. Also, can you please list the contraindications to regional anesthesia, sir?
Yeah, we can divide it into the absolute or relative. In absolute, if patient is refusing for regional anesthesia, raised ICP, puncture, infection at the puncture site, uncorrected coagulopathies, and for relatives, severe mitral stenosis, anticoagulant use, hypovolemia, and spine deformity.
Okay, right, sir.
Yeah.
There are lots of myths about regional anesthesia in pregnant females. So what are the various misconceptions regarding this, and what is the real deal actually when it comes to regional anesthesia? Can you please clear it?
As we all know, we are very fond of preloading. So in all patient undergoing for spinal anesthesia, we say no, we have to preload the patient to avoid hypotension. So in this patient, some people say no, preloading is mandatory. But in mitral stenosis, preloading may cause pulmonary edema. So fluid responsiveness should be assessed. And another myth is regional anesthesia may cause sudden hypotension. But incremental dosing with epidural, it should be avoided. Some surgeons say नहीं डॉक्टर साहब स्पाइनल एनेस्थीसिया में तो बहुत टाइम लगता है, उसमें तो कई बार आपको 2-3 बार पंचर लेना पड़ता है. But it is not true. with skilled anesthesiologists, it can be rapidly administered, either spinal or epidural. And then they say there is a high complication rate. But it has been found by many studies that regional anesthesia is more safer than general anesthesia while patient undergoing for a cesarean section in mitral stenosis patient.
Right, sir. So now I hope it's clear what is the fact and what is the fiction.
Yeah.
So can I be more specific in asking you the key considerations for general anesthesia in this patient, sir?
If you ask if patient is undertaking a general anesthesia, we can prefer etomidate or propofol. We should avoid drugs that can cause tachycardia or histamine release, like ketamine we should avoid, and atracurium, which releases histamine. We should look for the airway. We have to properly assess the airway of the patient, whether we have to anticipate whether airway is difficult or not. We have intraoperatively, we have to manage the patient on oxygen and muscle relaxation and titrate anesthetic depth to avoid hypotension. And we have to be very cautious while giving oxytocin also.
Yeah, right, sir. So I think with appropriate drugs, appropriate anesthetic goals, and appropriate intraoperative measures, general anesthesia also can be considered safe.
Yeah,
but
definitely.
Even general anesthesia has got its own advantages and disadvantages. Can you list that?
Coming to the advantage part, first and most important thing is we have a controlled ventilation in our hand. So good control of ventilation, we have a secure airway, and sometimes it is easier in emergencies. We have to when we are going for the general anesthesia. And coming to the disadvantages, some chances of risk of aspirations, neonatal depression, uterine atony, maybe when you are using inhalation agents. So we have to look for when you are looking using inhalation agents, and prolonged stay in ICU. Sometimes it is required. Yeah.
Yes. Okay, sir. Now, with the context of the above patient we are discussing, Dr. Yashwant sir, what can be the fetal morbidities associated with it? Dr. Yashwant sir?
Fetal morbidity could be because we are using beta blocker, we are using warfarin, we are using ACE inhibitor, furosemide. So they can cause, if you are using furosemide, that can cause hypovolemia, oligohydramnias, it can cause IUGR, and not only this, furosemide is ototoxic also. Due to use of ACE inhibitor, there could be oligohydramnias, and ACE inhibitor are teratogenic also. It can cause fetal renal damage, that is very important, leading to oligohydramnias, IUGR, and it can cause death. So there are both antenatal and perinatal mortality will be there. And due to IUGR, baby may develop, and preterm delivery, baby may develop infant respiratory distress syndrome. Due to hypoxia, baby may have difficult resuscitation at birth. Baby may have difficult Apgar. So baby may develop HI, hypoxic ischemic encephalopathy at birth. That can cause seizure, neonatal seizure at the time of delivery. Not only this, you are using beta blocker can cause hypoglycemia in the baby, and hypoglycemic seizure can be there. Baby will be IUGR preterm, there will be feeding problem. If there is uteroplacental circulation compromised, there will be compensation in the feeding. Baby will not develop feed up to for about 2 to 3 days. There could be low birth weight, and there could be increased risk of theoretical increased risk of cardiac genetic diseases, 2 to 3% in simple valvular disease, and if it is complex, it could be 3 to 6%.
Okay, right, sir. So, when choosing the right appropriate anesthesia for this patient, Dr. Premraj sir, what are the factors that will affect your decision making?
Again, we have to look for whether we are going to take this patient in an elective or in emergency. So, in both the condition, there is consent. Consent is very important from attendant and patient. Then urgency, whether if you are taking patient in emergency, so what the urgency, if there is a fetal distress or some other reason, we have to look for them. And what are the fasting status? Fasting status of the patient is important. But if we are taking it is an emergency, then we don't have to look for that fasting. We have to take the patient as soon as possible. If in elective, definitely we have to look for the fasting status of the patient. Then we have to assess the difficulty of airway and spine when we are performing the spinal anesthesia, and looking for the comorbid condition, whether the patient is having any comorbid condition or not. And we have to look for what are the drugs and in which condition we are working. So, and
Right.
if we have a proper equipment or not for that process.
Right, sir.
Yeah.
So can you also tell what are the anesthesia related concerns in pregnancy?
So what anesthesia related, first is profound hypotension. So in regional anesthesia, the chances of hypotension, supine hypotension due to autocaval compression, venous puncture while giving spinal anesthesia, and if patient is on anticoagulant and platelets count are less than 50,000, then we have to avoid that. In general anesthesia, chances of difficult airway, in chances of aspiration are high, and due to decrease in functional respiration capacity and increased oxygen consumption, we have to look for. And during intubation, then chances of injury, and it causes a bleeding mucosa also. So we have to look all these things.
Right, sir.
Yeah.
So after knowing all these concerns, how do you do the perioperative risk stratification as an anesthetist?
So again, we have to look for this patient. If we are taking is in an elective case, definitely it will be a ASA class 3 because it is having a severe systemic disease. And if in emergency, we can add 3 ASA class 3E. And RCRI score, we have to calculate the RCRI score, and for this RCRI score will be 1. Again, ma'am have discussed about the CARPLAG score, that we have to take it in the consideration also.
Right, sir.
Yeah.
So when managing such high risk cases, what
Yeah.
intraoperative monitoring do you consider essential, sir?
So we have to look for what ASA recommend. American Society of Anesthesiology recommend the monitoring like 5 lead ECGs, pulse oximeter, NIBP, and ETCO2 is must in all the patients. Then for advanced, we go for the arterial line, CUP for fluid management, cardiac output monitoring, and is patient undergoing for the GA, if we have GA, a BIS monitoring, then we can take BIS also in consideration.
Right, sir. Yeah. So are there any specific changes in the heart rate or blood pressure or any other hemodynamic parameters in such patients due to anesthesia drugs?
Definitely, like our inhalation agents, isoflurane, sevoflurane, it decreases SVR, mean arterial pressure, and so there is a chance of risk in the mitral stenosis patient. IV agents like propofol, it decreases systemic vascular resistance and also decreases mean arterial pressure. Whereas if we are using ketamine, we should avoid ketamine in this patient, which causes increased heart rate and mean arterial pressure. Opioids are stable, and neuroaxial blocks, when we are giving, it decreases SVR, decrease heart rate, if block exceed more than T4.
Right, sir. Also, is there any other specific drug interactions between the anesthesia drugs and the drugs which the patient is already taking?
Yeah, we have to look for which are the drugs this patient is on. Anesthetic drugs. Just wait a minute. Yeah. So we have to look for whether whether is on beta blockers or not, digoxin, or your diuretics. So we have to look for all these drugs. If patient is on beta blockers, so there are chances of bradycardia and hypotension when patients or when we give anesthetic gas like propofol or opioids. With muscle relaxant, there are chances of exaggerated hypotension. And again, if patient is on digoxin and with anesthetic agents like volatile anesthesia, the chances of arrhythmias are high due to myocardial sensitization. And with succinylcholine, there is an increased vagal tone, which causes bradyarrhythmia or heart blocks. If patient is on diuretics and using anesthetic agents like volatile, then chances of hypotension are high due to volume depletion. And with muscle relaxation, it can cause electrolyte disturbance. And
Right.
yeah, and there's something in anticoagulant and regional anesthesia, as I told you earlier, with spinal or epidural anesthesia, the chance of spinal or epidural hematoma are high.
Right, sir. Okay, sir.
Yeah.
So also there can be interaction between the uterine drugs and the cardiac medications, and they can have a total impact on the cardiac physiology as well. So Dr. Sangeeta ma'am, can you please throw light on this?
Yes, when we have delivered the baby, we usually get the option of oxytocin, methergine. Uterus is not contracting, then we ask the anesthetist to please give the carboprost. And now in our armamentarium, we have got the misoprostol also. But please, when the baby has delivered, the inferior vena cava compression has been gone. There is auto transfusion of blood. Please wait for the placental separation. Be very calm. Give, if the incision is there, secure your incised sites for the bleeding to occur less in these cases. Wait, give a good firm compression, hot compression, warm compression to the uterus, so that the placenta gets time to separate by itself. Because when the uterus is contracting, placenta is getting separated, still there will be some kind of auto transfusion to the heart of the patient. This will further compromise the status of the patient. So please don't jump and call your anesthetist, अरे oxytocin लगाओ, नहीं contract किया, methergine लगाओ. Give time for the uterus to contract. Give a physiological method of contraction, like if the baby is crying properly, baby can feed. The oxytocin, natural oxytocin is released in the body of the mother. The uterus gets contracted, or you can do the nipple stimulation, as in the Western society we people are doing. We have forgot in our patients. This can be of great help. And if it is required, it is up to our anesthetist or the co-person who is handling the hemodynamic status of the patient. Yes, oxytocin can be given in a dose of infusion if the uterus is not contracting. So please give time. Don't be very apprehensive to take out the placenta. If there in this stenotic lesion, patient is already having auto transfusion, some kind of blood loss will be a blessing in disguise to these patients, so that anesthesia person can get hold of the patient's hemodynamic properly. Yes, if the oxytocin is given, it can interact with the digoxin, can cause the prolonged QT interval. With beta blockers, hypotension may be there, sudden loss of SVR is also there, then there is like hemodynamic instability can occur. So please give these drugs judiciously. Although we don't prefer giving methergine, but if methergine is given, it will increase the afterload, increase the SVR, hypertension will be there. Although the patient was anxiety, was in pain, she will have spikes of blood pressure will be there. It will be not easy to control her hemodynamics. And usually we don't prefer carboprost, which can interact with beta blockers, can cause a bronchospasm and increase the pulmonary hypertension. And nowadays we are giving misoprostol also. We have to judicially use that also, because sometimes it can cause the coronary vasospasm and patient may go into sudden shock.
Right, ma'am. So I hope it's clear that we do not overload the patient with Synto and methergine. Thank you, ma'am. The next question I would like to ask Dr. Avdhe sir, what are the possible side effects of the drugs which we have used for the management of this patient?
Definitely, we are using few cardiac drugs which can affect the hemodynamics or physiology of the patient. And as Dr. Sangeeta had already stated, I want to add some points also in the previous question, because few hours just after delivery are the most crucial part in the whole history of this patient, because the majority of the patient can land into acute state of pulmonary edema, because cardiac output increases up to approximately 6 to 7 liters in such scenario because of auto transfusion. So we must be careful and watchful during that period. And regarding the drugs, if I talk, then basically in these cases, as a cardiologist, I will prefer to use diuretics, which can cause postural hypotension, acid-base imbalance, hypokalemia, and electrolyte disturbances, which can be corrected by fluid therapy or correct electrolytes. We can do it. And I will prefer to use beta blockers to control the rate. For beta blockers can cause hypotension, bradycardia, and they can also mask the episodes of hypoglycemia in such cases. So for that, we must withdraw and reduce the dose, and we can give fluids for hypotension and atropine for significant bradycardia. For digoxin, long-term use of digoxin in these patients can cause excessive nausea and vomiting, dyslipidemia, especially hypokalemia, which can be dangerous and leads to ventricular tachycardia or fibrillation in such cases. And in few cases also bradycardic episodes, which can be tackled with correcting electrolytes and giving atropine if needed, if there is significant bradycardia. For atrial fibrillation, because majority of these patients also had atrial fibrillation, so we are using anticoagulants in these patients, which can cause bleeding at any time prior to labor or during labor. So for that, we can you substitute unfractionated heparin. If we are giving to these patients, then we can revert it with protamine sulfate in a dose of 1 to 1.5 milligram per 100 units of heparin. We can also give intramuscular injections or intravenous injection of vitamin K up to 1 to 1.5 milligram. If we are using low molecular weight heparin, then we can revert its effect by using fresh frozen plasma in a dose of 10 to 15 ml per kg in such scenario.
Right, sir. Not forgetting about the baby, Dr. Yashwant sir, if the mother is taking these medications, what are the newborn considerations for this? Dr. Yashwant sir? Dr. Yashwant sir?
Yeah. So sorry. Yeah. So,
So what will
Dr.
be your
Avdesh,
newborn considerations?
yeah, Dr. Avdesh already answered. My job has been done. Basically, since we are giving anticoagulation to the mother, so if baby is at the birth, baby is every baby must be given vitamin K. And I was seeing the chat box. Someone has written you should go for G6PD before giving vitamin K. But this is not true. Only few cases are reported that vitamin K is causing hemolysis. 3, 4 cases are there. So two school of thoughts are there. Ki vitamin K should be given only after testing the G6PD. So if baby is bleeding at birth, what is the you cannot order ki go and test for G6PD. So you have to give vitamin K at birth and FFP for to control the bleeding in neonate. And to manage the pulmonary edema and hypervolemia, they are using diuretic furosemide. So we have to give fluid to the baby. Baby may be dehydrated, so fluids to be given to the baby. If baby is having low platelet count, we can give platelet transfusion and beta blocker, especially atenolol, which crosses the placenta, that can cause bradycardia. For this, we can give atropine if baby is severely bradycardic. If it is less than 100, we can start positive pressure ventilation. But when it goes below 60, we have to give atropine, and dose will be 0.02 milligram per kg IV bolus. If it not being controlled, then we can repeat after 5 minutes, every 5 to 10 minutes. If due to beta blocker, baby may develop hypoglycemia, and to prevent hypoglycemia, we have to maintain blood glucose level more than 45 milligram percent. So we have to start IV glucose infusion, or we can start the feeding. Baby is taking oral feed, we can give oral feed, or if baby is not taking oral feed, we can start nasogastric feeding, and frequent feeding is necessary to prevent hypoglycemia, because hypoglycemic injury to the brain is very disastrous, because it will run with the baby for lifelong, and digoxin can cause low birth weight baby. So these are the concern, and these are the management after birth.
Right, sir. So considering all the above side effects which we have discussed, Dr. Sangeeta ma'am, which are the drugs which need to be stopped before planning for pregnancy?
First of all, I would like to thank the patient that she has come in the preconceptional period to get the opinion of the doctor. Patients are getting worried, and they are getting good prescription from the doctors. As already been told that we should stop warfarin because it can cause the embryopathy. We should switch the patient to low molecular weight heparin, like in these cases of cardiac diseases. ACE inhibitors or ARBs should be stopped. If she is taking beta blocker, the safer beta blocker like labetalol, she should be switched over to. She is taking statins, those should be stopped. And if any other drug is she is taking, that category is to be seen. If it is safe, then only it is to be given to the patient, others to be stopped or given a better option for her.
Right, ma'am. Dr. Avdesh sir, if we are managing such a patient with cardiovascular issue, what do you think should be the minimum duration of postponing any elective surgery to get the safe effect of these cardiac drugs?
It's a very good question, and we must not be in hurry in such cases, and we must have a planned protocol in such cases. And so at least 4 to 7 days, as you have already stated, that 4 to 7 days must be there for proper evaluation of the patient, and we must pre-plan everything before proceeding for the delivery in such cases. So if there is no emergency, then there is no need to be hurry. No need to be in hurry, and we must take at least 4 to 7 days for proper planning in such cases.
Right, sir. So looks like you have to keep your scalpel sharp and even your patients more sharper while waiting for these medications to kick in. Right,
Yeah,
sir?
definitely.
Okay, sir. So finally, sir, I would like to ask you, do you need at least one cardiac follow-up before taking up case for the surgery after treatment?
Yeah, definitely a big SS. I will like to assess the whole scenario again, and each and every situation. I will like to assess the hemodynamic of the patient. I will like to repeat the echocardiography of the patient. What is the pulmonary artery pressure at this time? What is the valve area? Whether it is less than 1 or in between 1 to 1.5 square centimeters. And what is the INR of the patient? And what is the bleeding risk with the anticoagulant in in this scenario? So I will like to assess each and everything again and again and in a repeated manner in such cases.
Thank you, sir. So as we are nearing the end of the discussion, it is very clear that in high-risk patients, especially with the cardiovascular condition we have mentioned so far, we need a very proper and meticulous planning and also a very close coordination between all the specialities. Now I request our panelists, Dr. Anju ma'am, Dr. Deepa ma'am, and Dr. Anil Kumar Verma sir, to please proceed with the discussion.
Thank you, Dr. Neha. And I'm highly thankful to all my panelists, our cardiologist, pediatrician, obstetrician, and my colleague, Dr. Prem Raj, for going through such an informative discussion. And definitely there are so many points which has to be taken well for most of the students and the people who are leading day in, day out with such patients. So now my request to my chairpersons, Dr. Anju Griwal madam and Dr. Deepa, to throw some light as well as give their opinion regarding such patients. Any take-home message or points, relevant points?
Thank you so much, Dr. Anil. I think it is one of the very extensively and very well curated and webinar. We have practically answered most of the questions. I think one of the most important take-home questions is take-home points here are that we need to, have a very good coordinate multidisciplinary team looking at these patients from the very beginning. And as very rightly pointed out by Dr. Sangeeta, if they can come preconceptionally, that is excellent to have them there. And of course, monitoring and being in the loop with all of them will lead to safer outcomes. As far as anesthesiologists are concerned, and especially for this particular patient, I believe a very well titrated labor analgesia, if the patient is scheduled for an elective labor, and if it is an emergency, a low dose spinal anesthesia with fentanyl, and of course, a diligent close monitoring is extremely important. So I believe you have anyway answered most of the questions the students would like to, listen to that have been addressed in this. Dr. Deepa, would you like to put in your comments?
Excellent webinar. And as the case is multidisciplinary and it is the teamwork, I think a seminar with a multidisciplinary approach was just apt for this case. You have covered most of the questions. I would just like to add few more points. Now, we had one case where, as a cardiologist said, you admit the patient for 4-5 days just before the delivery. And this patient is an unbooked case and posted for BMB tomorrow, and on the previous day has a fetal distress, a category 1 section. So the anesthetist comes into the picture. We have to give anesthesia. So how do we go about? We have given general anesthesia. We delivered the baby, but post-operatively, we have not extubated the patient. We shifted straight to cardiology ICCU and requested them to go ahead with the BMV. So the patient was kept in the ICCU for some time, and then underwent a BMV and kept ventilated for some time and then extubated after doing a repeat echo and making sure that the valve is opened. That is one case I would like to say. Then about Wilkins score, you said about 8 or 10 and no calcification goes for a BMV. But what if the Wilkins score is more than that? Can we take this patient on a bypass? Yes. A pregnant patient with a high Wilkins score with calcification who needs a bypass, we have taken cases on bypass delivered opened up the valve, commissurotomy done. Of course, lot of care of the baby to be taken. The obstetrician very important because he'll put the patient on uterine relaxant. The perfusion is very important. We can't give too much potassium to this case. And then patient is admitted and then at term delivered. We have done cases like this. So that is another point I would like to tell. Another point which you could have discussed, I know for lack of time you might have not discussed, we can expect an arrest in this case, isn't it? So CPR in pregnancy with the the left uterine displacement and all the precaution, the perimortem cesarean delivery and the airway ventilation, which is very important, and IV access above diaphragm, and all those important points would have been added. And another important point which was also discussed is prostaglandins and this pulmonary hypertension. We did have a case where we have given prostaglandins for the uterine contraction, and the patient had sort of a pH crisis where the patient just has arrhythmias, and the CO2 just goes up and the hypoxia with hypercapnia. First response of the anesthesia, as the tube been misplaced, the tube has come out. The tube is fine, the air entry is good, but the PaCO2 is just rising and the saturations are just dropping. It is like pulmonary hypertension, and this situation is very, very difficult to tackle. You can lose the patient. So where it can be avoided, it should be avoided. And if the obstetrician feels like the uterus just cannot contract, and when the interventional person may be important to save the uterus. Thank you very much.
Thank you,
ma'am.
madam. And it is definitely very wonderful inputs by Madam Anju and Madam Deepa. Because yes, madam, you are very correct. Because I was not expecting that because it was already quite long panel discussion. So we just skipped few points, and definitely they are very important points. They should have been incorporated.
Most of the points, but these few points which came to mind added.
Okay. Yeah. Thank you very much, madam, for your inputs. And we have one more very important person who has joined this panel discussion. He is ex-director of LPS Institute of Cardiology. He's a cardiac surgeon and a very learned person, Professor Vinay Krishna sir. So, sir, आप just unmute होकर के, if you can just share one or two points regarding this case, sir.
Hello, am I audible?
Yes, sir. Yes, sir.
Good evening to everybody, and I am thrilled to attend this webinar, which has got such a good multidisciplinary approach for a problem. It has to be managed in the same way, and the only thing which I wanted to add was that if such full-term patient comes in emergency with severe mitral stenosis, then immediate emergency balloon mitral lyotomy is required so that the delivery can be conducted safely. I think we should not wait and plan for something else. So the madam was telling that the patient was posted for BMV next day, and the patient developed this fetal distress in the night, and it had to be conducted. It was a very Herculean task which they had done. But ideally, I think such patients should not be kept waiting or posted for a elective BMV. They should undergo BMV on the first priority. And in such cases, in our institute, many a times gynecologists have shifted their patients with critical mitral stenosis to our center, and where we did the mitral commissurotomy, and on the same setting, the conduct of delivery or like cesarean, etc., was done in Cardiology Institute itself. So with this remark, I want to congratulate everybody for organizing such a good multidisciplinary workshop, and thank you all for my giving opportunity to my participation. And one thing I think I can also tell that these patients have got a very high risk of deep vein thrombosis, which later on results in secondary varicose veins. So such patients should be advised to wear pressure stockings, which is given for varicose vein patients, grade 2 pressure stockings, which will prevent deep vein thrombosis in such cases.
Thank you, sir. Thank you.
Thank you very much.
Dr. Anil, I just want to add a point. As Madam had already stated, I came across a case. We have done BMV, and then on the next patient, the labor starts. The patient is around 36 to 37 weeks. Then we shift the patient to gynecologist, and then all the things were managed. So
Yes,
this
it
can
is.
happen before,
Yeah.
prior to procedure or after the procedure, because sometimes patient gone into a stressful situation because of the procedure also.
Exactly, it is on-spot decision, and definitely all the panel should decide it, and everybody has their own experience. Definitely, Madam is a very good and very senior anesthesiologist, and definitely it is a very good remark by her. And Madam Anju is also a renowned obstetric. Basically, she deals with the obstetric anesthesia majorly. So their remarks and their comment and their suggestion are very well taken. But as a cardiologist and cardiac surgeon, you are also the part of the team. So it is just a matter of fraction of second where the patient switches. So with thank you very much for all the discussion, and I definitely convey my thanks to our chair.
Sir, can I
of
ask one
this.
question?
Yes.
Can I ask one question, sir?
Yes, please.
Sir, I want to.
Please
there was some
introduce
doubt.
yourself. Please
Sir,
introduce yourself.
I am Dr. Rajesh Hirwani, practicing as freelance anesthesiologist in Mumbai, Maharashtra.
Okay, sir, welcome.
So I want to ask you, there was a doubt regarding regional anesthesia, especially spinal anesthesia in mitral stenosis patient, especially in moderate to severe. So given the understanding from today's seminar, what will be the preferred mode of regional anesthesia, spinal or epidural?
Actually, our anesthesiologist, sir,
Yes.
Dr. Premraj.
Yes, sir. You have to look for all the coagulation profile of the patient. A patient is having a moderate MS. You can proceed with combined epidural and low dose spinal anesthesia.
Even presently, the
Yeah.
segmental
And,
spinal
sir,
anesthesia is also being practiced, which has very less hemodynamic instability, and it has also very good results. One of the in chat box, one of our colleague has also already put this comment that segmental anesthesia should be preferred in these cases to prevent the over hemodynamic instability.
Sir, but for severe MS patients with the isobaric, we have not given segmental in those patients, but yes.
Yeah, actually, when the patient goes into the severe mitral stenosis, most of the day, those patients, they come into class NYHA class 3 and 4, as it has already been told. So in those patients, that definitely regional anesthesia may be a difficult option.
Definitely.
And too much hemodynamic instability and fluid shift, and that will be another problem. So it based on how much patient is symptomatic and the hemodynamic condition of the patient, how much is controllable easily.
Definitely.
So
Means
thank you, Dr.
Medico-legally, sir, sorry, sir, sorry,
Yeah.
Means
Please.
medico-legally, we can go ahead with spinal anesthesia in the moderate patients, moderate MS patients.
Yeah, definitely.
And sir, supposing the patient has undergone BME, then also, then is spinal anesthesia more safer as compared to not undergone any procedure?
After BMV?
Before, yes, after BMV, yes, sir.
Definitely, you can go for. You have to look for the profile of the patient and whether the patient is hemodynamically stable or unstable. And what is the
Dr. Rajesh, there are no black and white answers. You need to titrate to patient condition. The patient's clinical condition and the optimization time that you have to for optimization is extremely important to take a decision into what kind of anesthesia. And whatever your modality of anesthesia would be, monitoring throughout the perioperative period is the key to your outcome. So that's very important to remember. Ye nahi ki spinal laga diya and that's the end of the story. Right? So that is perhaps the key message that Dr. Premraj has been trying to give it to all of us. Thank you so much.
And Dr. Anil, in pregnancy cases, moderate mitral stenosis almost behave like a severe mitral stenosis because of hemodynamic disturbances. And after BMB, we are able to achieve a good mitral valve area. Then definitely the chances or risk are less.
Yeah, definitely. So, so hopefully this panel discussion has solved its purpose, and we are able to our panelists and with the guidance of our chairpersons, learned chairpersons, we are successful in delivering the message what has to be delivered in that. So our General Secretary of Research Society of Anesthesiology, if he and our President Sir, Dr. Naveen Malhotra, can give few points regarding it, or with their permission, we can further close the session.
So there has been only 3 words for this webinar: excellent, excellent, and excellent. A detailed discussion touching almost every corner. I don't think anything was left. And if anything was left, Madam Anju Grewal and Madam Deepa and Dr. Vinay Krishna sir nailed it perfectly, sir. It was a wonderful webinar and a truly multidisciplinary approach, sir. Thank you, Team Kanpur. Thank you, Dr. Anil Verma. It was a wonderful session, sir.
Thank you.
And
Naveen,
we will close the session now.
Sir?
Thank you very much. You want to say something, sir, Dr. Anil Verma, sir? Dr. Tejko,
no.
I would like to welcome our patron, Dr. Tejke Kaul, sir.
Sir, good evening, sir.
Sir, your sir.
Very good evening.
Sir, pranam, sir.
I was watching it intermittently, in between, right from the beginning. But somehow it was an excellent presentation, excellent discussions, and congratulations to the team Kanpur and all others who chaired it, who articulated the discussions, the president, the secretary, everybody. Excellent webinar, very good, very nice. Enjoyed it. God bless you all. Long live Rsacp.
Thank you very much. And we would close the session today. Long live Rsacp. Thank you very much. Good night.
Thank you, sir. Good night, sir.
Good night. Good night.
Thank you, sir. Thank you, sir.
Okay. Good night, everyone.
Good night, sir.
Good night, everybody. Thank you so much. Thank you.
Thank you, everybody.